Good morning, everyone. Thank you for joining us today for our webinar, The Obesity Epidemic and Its Impact on the Workplace. My name is Melina Cambizzi. I am the Senior Vice President of Business Development and Strategic Marketing here at the Alliance. I would also like to introduce my co-moderator for today's session, Ms. Jen Koberstein. Jen, welcome, good morning. Jen is the Program Manager at the Wisconsin Collaborative for Healthcare Quality, and you will hear us refer to the organization as WCHQ. Jen, I've been working with Jen for many months now. Jen is very passionate, very well organized. She is an incredible collaborator, and she brought all of us together for this very important work today and in the future. WCHQ is a collaborative that includes 36 Wisconsin health systems and their affiliated medical clinics. It also includes several dental practices, 2 payers, and now a broker consultancy as well. We will talk about the payers and the broker consultants here in a second. As a member-driven organization, WCHQ members publicly report clinical performance data and use that information to collectively drive improvement, promote transparency, and increase equity in healthcare. Again, welcome, Jen. We're excited to have 230 people registered for today's webinar, so welcome to all of you. A couple of housekeeping items. You're all in mute mode, but of course, as always, we always want to hear from you. Please use the chat feature to ask your questions, and if you're experiencing any technical challenges, type your issue into the chat box, and our tech support team will work on addressing it directly with you. Please note that the presentations and handouts from today's event will be made available on the events page on our website. I am sure Jen will make it available on WCHQ's website as well. And of course, we'll email a link to all attendees next week. I would like to say a big thank you to our sponsors next. Big thank you to the executive sponsor for this event, Novo Nordisk. We would also like to thank National Cooperative RX and Delta Dental. They are our year-long platinum sponsors. We appreciate the ongoing support for all of our great sponsors, that they help us to continue to bring valuable programming to our employers. So let me start by saying this effort, near and dear to my heart, is the first of its kind where providers, systems, payers, big pharma, we all came together, we're all coming together to recognize that obesity needs to be treated as a disease. We're working together agnostic of competition, agnostic of overlap in services, because we take this very seriously. There is some special recognition that's appropriate here. First, a big thank you to our providers and program managers from 36 systems that have come together recognizing the seriousness of the obesity epidemic for our state and our communities, and who have worked together. We've worked together before hours, after hours, at lunch. Anytime they had a break in their busy days, we would take the opportunity to work to bring this and other programs together for all of you. There are also 2 payers to be recognized in this effort. My colleague, Mark Sistris from HPS, has worked tirelessly with the team, and I have had the honor to represent the Alliance in this effort. Also, M3 is now part of WCHQ, and our colleague, Cindy Van Asten, who I know is listening today, is representing her organization and the consultant community in general. For those of us who know Cindy, we know that her passion for health and wellness is immeasurable, and she's a leader in this area for her community and her employer clients. We, Jen and I, and all of us, we would like to invite many more innovative consultants to join us, because this is a big effort that affects all of us. If I can just be indulged and take a moment to speak from the heart. For me personally, obesity is a daily battle. And so if I can be a tiny, tiny speck in this journey to help my employer clients, our fellow Wisconsinites, to overcome the disease and live healthy and happy lives, well, then that's life's work. We believe that if we all come together, we can help in eradicating a very serious illness that can lead to very serious conditions and very expensive treatments. Today, we will hear first from 3 doctors working in obesity medicine, each an expert that brings different training, different approaches and perspectives to the treatment of obesity. And then at 10 a.m. from 3 employers who are pioneers in bringing health and wellness to their companies and communities. Please jot down your questions. We will address them at the very end of today's provider presentations, as time allows, or during our panel discussion around 10 a.m. I now would like to turn it over to my colleague Jen to introduce our speakers, our provider speakers, and host the panel for them.
Thank you, Melina. WCHQ has been extremely pleased to have an opportunity to involve payers in our efforts to improve care for those who have the chronic disease of obesity. I'd like to personally recognize the Alliance, M3 Insurance and Health Payment Systems, along with several of our provider-owned health plans who have invested their time and effort into this project. The commitment of these organizations to help educate not only providers, but also employers and payers on the significant impact that they can have on changing the dynamic for treating people with obesity. It is now my pleasure to introduce Dr. Christopher Weber. Dr. Weber is an internist, pediatrician, and obesity medicine specialist and serves as the medical director for Ascension, Wisconsin's Bariatric Service Line. He sits on several committees of the Obesity Medicine Association, participates in obesity-focused clinical research, and is involved in medical student and resident education. Dr. Weber has spent many hours working with payers, providers, and systems to advance evidence-based treatment for people with the disease of obesity. We look forward to his presentation. As we know, this is a topic that can help to significantly improve outcomes in the workplace. Thank you for being here today, Dr. Weber.
All right, thank you so much for that introduction, Jen. And Melina, thank you for the opening. And thank you to all the attendees for being here. This is an incredibly important topic, and we're going to jump right in. So this is obesity in Wisconsin, more of a just obesity in general overview, but we do have some Wisconsin specific information here. So just a broad overview. We'll get into treatment support and just general considerations. Okay, so you all maybe have an idea of what obesity means, right? What's the definition of obesity? I think most people would think BMI 30 or higher, right? That's obesity. Very straightforward, easy to measure. We use that on the population level all the time. I like this definition. So this comes from the Obesity Medicine Association. I'm just going to read it here. So obesity is defined as a chronic, progressive, relapsing, treatable, multifactorial neurobehavioral disease wherein an increase, wherein an increase in body fat promotes adipose tissue dysfunction and abnormal mass physical forces resulting in abnormal metabolic, biomechanical, and psychosocial health consequences. Okay, so that's a little harder to measure when you're looking at pulling data and looking at some of the numbers and information, but I think it teases out a few very important aspects about obesity. I'll just highlight a few of those. So one is it's a chronic disease, right? So we got to look at this, if we're not already looking at it, like other chronic diseases, like type 2 diabetes, like high blood pressure. You see crash diets where people lose a bunch of weight for a few months and they gain it back, right? So it's chronic, it comes and goes, it relapses, but it is treatable, right? You don't throw your hands up and say, I regained the weight, there's nothing I can do. No, there's definitely treatments, and we'll get into some of the treatments that are getting more and more robust as we learn more and as time goes on. And it's also very multifactorial, right? One reason I like this definition is because I sound smart, right? There's a lot of big words in here, psychosocial, biomechanical. And so there's a lot that's going on, all these different neurohormonal pathways, hormone signaling, and we'll get into a little bit of that, but it's very complicated, which is one reason that it's very difficult to treat. Okay, so obesity is a chronic disease. So let's look at this circle here. I'm not sure if you can see my pointer or not, but it's there. So lots of different things that contribute to obesity, both causing obesity, but also resisting weight loss. Bodies do not like to lose weight for all sorts of different reasons. Look at this first one on top here. Sleep and stress. Anybody have any issues with sleep and stress the last 2.5 years or so, right? I mean, with the COVID-19 pandemic, this has been a significant issue, right? Staying up late, sleeping in, your schedule's all off, you're stressed. That alone can lead to weight gain and weight loss resistance. Nutrition obviously is very important, one of the cornerstones of obesity treatment. Medication, so I cause weight gain, my apologies, but there are prescription medications that can lead to weight gain. And a large part of what I do is trying to change people off of medications that cause weight gain to more weight neutral or weight loss promoting medications. And then socioeconomics, is there affordable, healthy foods available or is there not? And then on the left side of the circle here is all the physiological things, which we're getting more and more information and more comfortable with what's going on here, but it's not out there. I don't think the general public is aware of all of this. There's all these signals that like I've said, control and resist weight gain. So there are gut hormones. Ghrelin is a hormone that increases hunger, and that changes as you're trying to lose weight. You can get more hungry over time. I use the word neurohormonal already. A lot of this is controlled up in the hypothalamus in your brain. Adipose tissue itself. Okay, so adipose tissue, fat cells, they don't just sit there and give us a little more insulation in the Wisconsin winters, right? They do all sorts of stuff. They secrete these inflammatory signals, and like other chronic medical diseases, it gets dysregulated at some point. So you get a certain amount of excess adipose tissue. The signaling is off, and that leads to some of the pathology that we'll see on subsequent slides here. Okay, so where are we right now in Wisconsin as far as obesity prevalence? So the way we define this is the percentage of patients between 18 and 85 whose most recent data that we were able to pull meets the defined targets considered non-obese, so kind of a reverse definition. So those who are not obese have a body mass index of less than 30 without any additional weight-related medical conditions, or a BMI of less than 27 if they do have weight-related medical issues or Asian descent. There's some ethnic differences with the definition of obesity. So what we have, at least with the WCHQ member patients, close to 59% met the criteria for obesity looking through December 2020, right? So that's a lot of people. That's a lot of people meeting the definition for obesity. Okay, so this slide here looks at the trends of obesity. I believe this is national data, not specific to Wisconsin. 2010, 30.9%, and then extrapolated to 2030, where it's expected to be 42%. And if you see the fine print down here, it says if you follow the current linear trend, could reach 51%. And this is a number that I've seen quoted more often. So by 2030, the expectation is somewhere around half the population is going to have obesity, okay? And along with that comes all of the, I call them ABCDs, it's kind of cute, adiposity-based chronic diseases. So all the diseases that obesity causes, which we'll get into in a minute here. And then this picture on the right here shows, yeah, obesity is going up, BMI greater than 30, but more extreme obesity is going up even faster, even faster. Okay, so what do you do about it? Okay, what can you do about this? And you'll see here, benefits of a 5 to 10% weight loss. Okay, so like I said from that first slide, obesity is treatable, and then as the weight comes down, all of these weight-related ABCDs get better as well. Now, I'll tell you, in my experience, everyone's got different expectations, but often I'll sit down with someone and say, okay, if you lose 5% of your weight, all this stuff is going to get better and you'll prevent all these other potential health issues. And we run the math, we get a calculator and we tell them, 5%, whatever that is. Often it's just kind of estimating here. Often it's around 15 pounds, maybe something like that. And some people will say 15 pounds, Dr. Weber, that's not that impressive. That's not that much. I want to lose 100 pounds, but that's all it takes. That's what these studies show. So losing 5 to 10% can benefit a person tremendously, and then you extrapolate that to the entire population. People with obesity, really significant improvements in all of these things. So reduces your risk of type 2 diabetes, cardiovascular disease, improves triglyceride and HDL numbers, decreases sleep apnea, severity, and improves, I think this one's important, very important, the health-related quality of life. And then down here, so some economic benefits as well, reduced absenteeism and reduced presenteeism. So real tangible benefits with healthy weight loss. Okay, so I mentioned a few times all these other ABCDs, these other medical conditions that obesity can cause. So you see, this is a small list of them. Some of the, say, heavy hitters, the more important ones. So there's a lot of focus on diabetes, right? If someone has obesity and you address the obesity, blood sugar is going to get better. Blood sugar is going to get better. Sleep apnea, same thing. Sleep apnea can go away with sufficient weight loss. The musculoskeletal component, so that's an quality of life also, but also all the cost for joint replacements and those sorts of things. That can get better. You know, I've had patients who come to see me, they need to lose weight before their joint replacement, and they lose enough weight and their pain gets better. They don't need the replacement anymore. And cancers here, so there's somewhere around 20 cancers that you have an increased risk for if you have obesity. So there's a lot going on here. One other one I just want to tease or highlight here is non-alcoholic fatty liver disease. Okay, it's coming, right? So you look at the rates of obesity increasing and the rates of non-alcoholic fatty liver disease. That trend follows obesity by a few years. So that's going to be a big time issue coming up here. And as of right now, there's not a lot of good treatment specifically for that. So it's going to be treating the obesity to prevent all the complications of fatty liver disease and cirrhosis and so on. Okay, so what do you do about this? So these are 4 of the main pillars that we go after, and we'll get into each of these here from a high level overview. Nutrition, you got to talk about nutrition. That's one of the most important parts. I do want to say just the relative potency of these interventions. So with nutrition and physical activity, self-directed, you know, on average, people lose somewhere 5 to 7% of their weight. Medications, we're talking somewhere about 5%, and some of the newer medications getting close to 20% total body weight loss. Some that are in preclinical trials right now, even a little bit more than that. In surgery, we're talking even more weight loss. So that's the more weight loss as the interventions get more intense. So nutrition, I just put a smattering of different examples up here as far as what kinds of diets to use. And I'll tell you, this might sound common sense, but everyone's on a diet, right? Just most people are on a standard American diet. And then when they go to anything else, they say, no, I'm on a diet. Now everyone's on a diet, just most people are not on a great diet. There is, this is my opinion, it's not WCHQ approved statement here. There is not a single diet that is better than another diet for total body weight loss. You know, if you want to do Mediterranean, fine, we can work with that. If you want to do a keto diet, fine, we can work with that. You know, and again, in my opinion, I think caloric restriction is the number one most important thing for total body weight loss. Now, for overall health, and you know, you have insulin resistance or you have hyperlipidemia, high cholesterol, then some of the particular food choices make a difference. So overall health, you get into some more details. You want to eat stuff that's in the photo here. I want to point out werewolf diet here. Okay, people really want to lose weight and they'll try all sorts of stuff. Look up the werewolf diet. It's not one that I promote, but it gives you an idea of, you know, what people are willing to try to lose weight. Which is one reason I think that having a really well-established, medically focused clinic or program is important, so you can tease out, hey, what's really going to help and what kind of maybe is just media. Okay, physical activity, real briefly on physical activity. I often don't spend a lot of time talking about this with people because, believe it or not, most people don't lose a lot of weight with physical activity. Now, once you lose the weight, it's important to keep it off, but it's not one of the more potent interventions that we have. So let me just explain what this means here. So resting energy expenditure, of all the calories that your body uses during the day, 70% of the calories are just to keep you alive, heartbeat, lungs breathe. So that's the vast majority of it. Thermic effect of food, this is the amount of energy it takes to break down the food that you're eating. Okay, and then physical activity, this isn't exercise, this is just getting up and doing your usual business. accounts for 20% of your energy expenditure. And then just one line here about the variation. You hear people say, yeah, I have trouble losing weight because my metabolism's slow, or I can lose weight easy because my metabolism's fast. But really, when you tease it out, there's not a lot of variation person to person. There's some, but it's usually not that dramatic. So energy expenditure, not a lot of variation person to person. Okay, let's move over to medications. I'm not going to get into specific medications here, just medications in general. So when does someone qualify for a medication, or when would we use one? Well, if they have obesity, basically BMI 30 or higher, you qualify for a medication. Or if you have a BMI down to 27, but you have one of those ABCDs, those adiposity-based chronic diseases. And there's, going back a few slides where we talked about the different pathways that cause obesity. These medications work in different parts. Some work on gut hormone signaling, some work in the hypothalamus and neurotransmitter signaling. So they work by different mechanisms here. We're not quite smart enough yet to know which one's going to work on which person, but maybe someday we'll get there. And kind of getting to the most potent intervention is bariatric surgery. There's a few different kinds of bariatric surgery. Indications for it: BMI 40 or higher, regardless of whether you have any of those ABCDs, or BMI 35 or higher if you have an obesity-related medical condition. And that, I believe, is, that's the last slide. So thank you for listening. Just, the highlights here: obesity is a chronic disease, and we got to start looking at it and treating it like other chronic diseases. And I would say it's maybe the most important chronic disease because it causes all of these other chronic medical conditions and all the health complications and costs that are associated with that. So I really appreciate you listening and your interest in treating this really important disease. Thank you.
Thank you, Dr. Weber. I would now like to introduce our next speaker, Dr. Melanie Smith. Dr. Smith is board certified in family medicine and a diplomat in obesity medicine and the medical director of the HMR program at Aurora. She is passionate about helping patients to get healthy, to control their chronic diseases, and bring her expertise to lead Advocate Aurora's system-wide initiative in building a comprehensive weight management strategy. Welcome, Dr.
Want to make sure that you can hear me okay?
Perfectly.
Okay. So Dr. Weber has shown us that obesity is epidemic in our country. And we believe that over 70% now have at least overweight or obesity. And we know the disease of obesity is a driver of chronic disease. He did mention that, there's 237 different diseases or conditions that are associated with the disease of obesity. We have evidence-based treatment, which he's alluded to, yet we have some inconsistency on treating obesity. Some of that, I think is the conversation's difficult for some clinicians. They don't have insurance coverage for medications and surgeries. And some of it is just that people are not aware that obesity is a disease and we do have evidence-based treatment. But hopefully we see that this is really changing. I'm going to try to convince all of you that it makes more sense to treat the disease of obesity to affect many diseases than just to treat the one disease alone. So to that point, I'm going to recommend that we treat obesity to reduce the cardiovascular risk in type 2 diabetes. So we know that heart disease remains the leading cause of death in the US. And we also know that cardiovascular disease is the principal cause of death and morbidity among people with diabetes, especially type 2. So there's 2 to 4 times increased cardiovascular risk compared to adults that do not have diabetes. And diabetes has many related macrovascular and microvascular complications, including coronary artery disease, cerebral vascular disease like stroke, heart failure, peripheral vascular disease, chronic kidney disease, diabetic retinopathy, and autonomic neuropathy. And these are the things that are responsible for impaired quality of life, disability, and premature death associated with diabetes, not to mention the higher medical expenses. We also know that obesity leads to insulin resistance, which leads to a lot of fat deposits in the circulatory system. This creates a lot of inflammation and leads to endothelial dysfunction. So this dysfunction is associated with a lot of these cardiovascular conditions like atherosclerotic disease, hypertension, and hyperlipidemia. So I'm just kind of trying to show how everything really overlaps. We know that type 2 diabetes is different than type 1. So type 2 diabetes, the pancreatic cells are not producing enough insulin, but we also have this peripheral insulin resistance. So the insulin pump is not working to really uptake that insulin, the blood sugar, I'm sorry. And I'm not going to go into the pathophysiology of hyperglycemia, but when we have beta cell dysfunction and insulin resistance, again, we start seeing that the glucose uptake goes down, our muscles aren't getting the glucose, and we start producing a lot more adipose tissue. So what can we do about it? And again, Dr. Weber really touched on this, that in the clinical studies, it showed a weight loss of around 5 to 10% can result in a reduced risk of type 2 diabetes and cardiovascular disease. And now that we have better anti-obesity medications and bariatric procedures and surgeries, we can increase the likelihood of achieving clinically meaningful weight loss. And this is just a touch on some of the studies, but you can see 3 to 10 to 15% was shown to be therapeutic benefit for all these different diseases. And he also did talk about the different treatments. I do put in behavioral as a third lifestyle treatment besides nutrition and physical activity. And we want to treat this in a staged approach based on a person's BMI, which is what we go by right now. That is kind of leaning towards we'll probably do more body fat percentage up the road, but this is the standard for right now. So a BMI of 25, anything over that, we really want to counsel on nutrition, physical activity, and behavioral, including things like sleep hygiene, stress, etc. Once they hit a BMI of 27, if they have a comorbidity, we should be introducing pharmacotherapy, and for everyone with a BMI over 30. And once they hit a BMI over 35, if they have a comorbidity, we should be introducing bariatric surgery. Now, I just want to look at one particular condition here, pre-diabetes. A lot more talk has been given to pre-diabetes now, and it's really important. So pre-diabetes is a common problem and strongly associated with obesity. So we have 84.1 million people in the US that more than 1 out of 3 adults have pre-diabetes. Yet 9 out of 10 of them don't even know they have that. So if you were to treat obesity with all the interventions that we have, people start eating healthier, they're more active, they're being treated with medications, they've had surgery, we would be cutting the risk of getting type 2 diabetes in half. And I think we're all well aware of the cost of what diabetes is. So if a person has pre-diabetes, and that's that middle row in there, you can see pre-diabetes, what the definition is. If they have pre-diabetes, there's an annual conversion rate to full-blown diabetes of 12.2%. But there's a lifetime conversion rate of up to 70% without treatment. Patients who convert to diabetes are 2 to 4-fold higher risk for cardiovascular disease and all those things we talked about, and they incur 230% higher healthcare expenditures, around additional $9,600 per year. So in a diabetic prevention pilot that CMS did, they feel that if you were to treat 100 high-risk adults, people with pre-diabetes, age 50, for 3 years, you would prevent 15 new cases of type 2 diabetes, prevent 162 missed work days. You would avoid antihypertensive and cholesterol medicines in 11 people. You would avoid $91,400 in other healthcare costs, and you would increase 20 years of health. So I wanted to just show you, we did this in Advocate Aurora. We have a pilot right now that unfortunately we're not completely wrapped up, so I can't really give you the outcome data. But I just wanted to show you, just taking all that information, what that could mean for a system. So in Advocate Aurora, we know we have 231,315 patients with pre-diabetes. Now, if 12.2% of them are going to convert, we would have 28,220 patients, new cases of diabetes. Now, if you multiply that by the $9,600 in medical expenditures that's attributed to diabetes, we would have $270,912,000 of expected excess medical expenditures without any intervention. Now, if we treated 250 of those patients, we would avoid 15 cases of diabetes per 100. And again, at that $9,600 excess medical expenditures avoided per average, I'm sorry, I can't get my slide to go. There we go. So we would have 364,000 expected avoided excess medical expenditures just from this pilot of treating 250 patients. Now, assuming that we scale this up to 10%, just 10% of the Advocate Aurora pre-diabetic population, so that would be 231,315. 10% of that would be 23,132 patients. And again, 15 cases avoided per 100 treated, we would avoid 3,470 cases of diabetes. And again, at a $9,600 per year, we are talking about $33,312,000 expected avoided medical expenditures just from a 10% scale up. So in summary, I hope I've convinced you that we have an epidemic of people with a disease of obesity. 90 to 95% of patients with type 2 diabetes have this disease. Diabetes and obesity are the driver of cardiovascular disease. And again, we know that cardiovascular disease is still the leading cause of death in our country. So it makes sense by treating obesity, we can reverse type 2 diabetes, lower cardiovascular disease, and in many cases, even prevent diabetes in those that were headed in that direction. Thank you.
Thank you, Dr. Smith. Excellent presentation. Next, I'd like to introduce Dr. John Briggs. Dr. Briggs is a licensed psychologist with patients and families who are pursuing healthier and active lives through weight loss with bariatric surgery. His work is done through the Metabolic and Bariatric Surgery Program at Theta Care Regional Medical Center in Neenah, Wisconsin. And he provides services at Theta Care Behavioral Health, Menasha, Wisconsin. Dr. Briggs has several academic appointments, including Marquette University and UW-Madison. Welcome, Dr. Briggs. We are thrilled to have you join us today.
Thank you. And especially thanks to the Alliance and the Wisconsin Collaborative of Quality, Healthcare Quality for putting on this important event, and all the participants, as well as Dr. Weber and Dr. Smith for their informative presentations. So hopefully this will be useful to all of you as well. And I believe we're in good shape.
You are.
Thank you. Appreciate that. Particularly Dr. Weber and Smith went over a lot of this stuff, so I'm not going to bore you with redundancy. So I'm going to flip through some of these early slides pretty quickly. But for the program here at Theta Care Bariatrics, We basically have our patients participants go through a orientation introductory class, and then they have a minimum of 2 meetings with registered dietitians and a minimum of 2 meetings with exercise physiologists. And then, of course, a meeting with me, a psychologist, or my colleagues for a psychological evaluation, which includes some pretty comprehensive psych testing, and then developing a treatment plan to help people evaluate their appropriateness for bariatric surgery or weight loss surgery, and to help them be successful with the same. And it's a pretty comprehensive program. That involves a lot of different avenues, including the ancillary providers of their primary care physicians, OBGYN, pulmonology, cardiology, endocrinology, and oftentimes orthopedics and neurological specialists for those patients with chronic pain issues. But all the patients before going through bariatric surgery go through an endoscopy, and fairly routine endoscopy, and then are evaluated and determined for which procedure they might be recommended for, either the Roux-en-Y gastric bypass or the laparoscopic sleeve gastrectomy, both of which procedures are done robotically here. And then also the all-important, very comprehensive aftercare programming. So you've already seen, I think Dr. Weber talked about the benchmarks or the definitions of obesity, which you see on your screen here again. And then the big reason why I want to put this up here, and the other presenters have already talked about this, is just to get a greater understanding and awareness of how pervasive or how far-reaching and multifaceted the tentacles of obesity reach throughout our healthcare. I'm not aware of another healthcare issue or disease presentation that has such a multifaceted and far-reaching impact on almost every other area of our health. And so, as Dr. Smith was talking about, diabetes mellitus, the hyperlipidemia, and hypertension, of course, heart disease, stroke, and then cancer, as I think Dr. Weber had talked about, and then in the musculoskeletal issues and chronic pain, and the list goes on and on. Like I said, I won't bore you with a lot of this extra detail, but you can see it as I flip through it on the slides. But from a psychosocial perspective, the impact of obesity is tremendous, particularly in areas of depression, anxiety disorders, and even dementia. And just because we're in that era that we all love being in right now with the COVID-19 pandemic, we all know that there's an increased risk for intubation, hospitalization, intubation, and death with obesity with the COVID-19 pandemic. The people that struggle with obesity have a 46% greater risk of COVID-19. They're at a 113% higher risk for hospitalization once they contract COVID-19, 74% higher risk of ICU admission and intubation, and a 48% increased risk of mortality with COVID-19. And Dr. Smith touched on this a bit as well. In the United States in 2017, it's estimated that the cost of obesity was $1.4 trillion. And I suspect that that's a rather conservative estimate, and no doubt above and beyond inflation that we're dealing with today. But with the increased numbers of obesity over the past 3 years, especially 5 years, that number is much greater today. People with obesity and morbid obesity are 300% more likely than the general population to be on disability and pull on those benefits. In the workplace, people who are obese or morbidly obese have twice as many sick days as their co-workers with healthy weight presentation. And of course, particularly for employer groups that are self-insured, self-funded rather, there are significantly higher pharmaceutical costs across the board, especially in diabetes medicine, in terms of pharmaceutical costs. So one thing that doesn't get talked about very much, particularly for employer groups, is there is some ancillary liability and risk management issues that go along with employees with that are overweight, obese, and morbidly obese, and some of these are anecdotal awarenesses on my behalf from patients that I've worked with over the years, but our obese and morbidly obese coworkers are more prone to bullying and harassment in the workplace, and issues associated with hostile work environments. They're more likely to experience some form of discrimination. There are understandable personal hygiene issues that go hand in hand with obesity, which create issues in the workplace. I'm aware of a handful of cases where employees have, in 2 cases in particular, where employees have dropped out of the workforce after there were complaints to human resources about sexual harassment because their clothes didn't fit, and when they were bending over to pick things up, they were exposing things, and just created an awkward situation and unfortunate for the employee as well as for the employers. There are also safety issues. Fall risks are greater, and then costs in terms of facilities, in terms of office furnishings and this type of thing that we need to accommodate for our employees. And there are also DOT issues, Department of Transportation issues for employees that drive, even forklifts and stuff in a manufacturing setting or a warehouse setting, in terms of sleep apnea issues, in terms of seatbelt extenders and this type of thing. And these issues all add up and also play a major factor in the employees' psychological health and psychological well-being. The greatest impact of obesity in terms of our psychiatric or psychological health are in the areas of clinical depression, anxiety, including rising generalized anxiety, panic disorder, social anxiety, obsessive compulsive disorder, and then of course post-traumatic stress disorder, which I'll talk about here in a moment, chronic violence exposure, issues of sexual assault, rape, child molestation, incest, and sex trafficking, as well as just eating disorders in general. With specific focus on depression, there is a symbiotic relationship between obesity and depression. One meta-analysis demonstrated that individuals with obesity have a 55% increased risk for depression, and conversely, individuals with clinical depression have a 58% increased risk for obesity. Again, it's a rather strong symbiotic relationship. And then similar factors in terms of the relationship with obesity and anxiety. Again, it's a chicken and the egg argument in terms of what causes what or what contributes to what, but people with obesity are 60% more prone to generalized anxiety, social anxiety, panic disorder, or post-traumatic stress disorder. And of course, people's personal self-perception and social construction of their abilities, their vocational self-efficacy, their confidence levels, and their psychiatric well-being, particularly in terms of anxiety, are greatly impacted by obesity, especially with the obvious issues of shame, isolation, withdrawal, and avoidance, sedentary lifestyle, and especially in terms of trauma. In that regard, the CDC reports that 1 in 6 boys are sexually abused before the age of 18, and 1 in 4 girls are sexually abused before the age of 18. I suspect that those numbers are a bit low, and we are increasingly becoming aware that those numbers are significantly higher in the context of COVID-19, which is easy to understand if you conceptualize issues of isolation during the pandemic, proximity, of the victims to their abusers, as well as limited access to services, particularly during the first year to 2 years of the pandemic. There are many studies on the relationships between trauma and obesity, and all of them suggest that there is a strong relationship between trauma and obesity. On the very low or conservative estimate, 30% of people who struggle with obesity and morbid obesity have experienced trauma, likely sexual trauma in their lives. And some studies, it goes as high as 90% of people that struggle with obesity and morbid obesity have experienced traumatic experiences in their life, especially sexual trauma. Overall, one meta-analysis indicated that there's an 87% correlation, which is a very high predictive rate, 87% correlation rate between adverse life experiences or PTSD, binge eating disorder, and obesity. I also want to touch on musculoskeletal and neurological issues because there is also a strong relationship between obesity and chronic pain. Those conditions definitely coexist. In one study of patients visiting the primary care clinics or offices, their complaints of chronic pain in the most recent 3 months, only 3% of patients presented to primary care with healthy weight complain of chronic pain in the past 3 months. That number more than doubles to 7.2% of patients in the obesity classification, and that 3% number is almost fourfold at 11.6% of patients with morbid obesity complain of chronic pain within the past 3 months of their visit. In terms of overall subjective reports of pain severity, and these numbers are relative to patients with healthy BMIs. Overweight patients rate their pain as 20% more significant or greater than those with healthy BMIs. Individuals or patients with class 1 obesity, they rate their chronic pain or the pain symptoms as 68% greater than those with healthy BMIs. Class 2 obese patients, 136% greater, and morbidly obese patients, 254% greater severity of pain indications or pain complaints. To bring it more home, I'd like to present a couple, 2 or 3 case studies. Definitely change some of the details and demographics to avoid the risk of revealing identities. But in a recent success story that we've worked with is a 40-year-old woman, Caucasian of European descent. She was a teenage mom, but she did graduate high school and later also went on to college and earned her bachelor's degree. She is currently working in a professional position in sales and marketing. She's been a single parent, never married, never divorced. Her son, her child that she had in high school is now 22 years old and is soon graduating from college. She reports lifelong struggles with weight and obesity problems. In 2010, when she was 28 years old, she was 5 foot 5 inches, 247 pounds, and her BMI was 41 in the morbid obesity category. She was otherwise healthy at that time. She was on no medications other than birth control, but she was interested in bariatric surgery, but her insurance denied coverage for bariatric surgery because she was too healthy. A few years later, at age 31, in 2013, her weight had increased to 260 pounds and her BMI was 43. Again, she remained otherwise healthy, and again, her employer's health insurance did not cover bariatric surgery. In 2014, as circumstance would have it, she was diagnosed with uterine cancer which was treated, and she did recover and is in full remission. But in 2016, at the age of 34, she weighed 290 pounds and her BMI was 48. She once again was interested in bariatric surgery but didn't have insurance coverage. In 2016, 2 years later, she was still with the same employer, but by this time she had developed generalized anxiety disorder, symptoms of major depressive disorder, obstructive sleep apnea, acquired hypothyroidism. She was pre-diabetic, experiencing migraine headaches, acid reflux, and she was on an SSRI such as Prozac and fluoxetine, Xanax, Topamax for the migraines primarily, and Prilosec for her GERD. Again, she was interested in bariatric surgery, but her employer's health insurance did not cover bariatric surgery. And so fast forward to 2020, this is when I met this individual. She had changed jobs primarily because she was looking for an employer that had insurance that would cover bariatric surgery. She did find that. And at this point in 2020, she was 38 years old, but 305 pounds, and her BMI was over 50. At this point, she was on a number of medications comprising Lipitor, Wellbutrin XR, Zoloft, Voltaren, Trulicity, estrus, levothyroxide, and metformin. And as Dr. Smith was indicating in her presentation, you can imagine the month-to-month costs, both in terms of the employee's out-of-pocket expenses, but also in terms of the third-party expenses for all these medications. In March of last year, she did undergo laparoscopic robotic Roux-en-Y gastric bypass procedure, and I met with her a few weeks ago just to see how she was doing on follow-up. And she's now 40 years old. Her weight is 175, and she's still losing, and her BMI is back in a overweight but much more healthy position of 29. She has resolved many of her health issues, and she's only now prescribed and taking or using estrus, Prilosec or omeprazole, and of course the bariatric vitamin regimen. So the expenditure and costs are impressive. Her health and well-being and psychosocial status has greatly improved. It's rather enjoyable to hear her talk about how she actually enjoys walking and running up the stairs at work, what she used to avoid it like the plague. And she's one of the few individuals that I've known that has celebrated going back to the office and workplace as opposed to working at home, just so she can run up the stairs. So another case study, definitely a more tragic story, a number of levels. This is a 35-year-old African-American woman. In 2011, she was 24 years old, single, never married, no children, a high school graduate, and she was employed full-time as a laborer in a manufacturing environment. But she was morbidly obese at 385 pounds with a BMI of 64. She was remarkably otherwise healthy, and she did express an interest in bariatric surgery, was evaluated at that time and went through the process and was approved for bariatric surgery, but declined because she thought that she wanted to try one more time to do it on her own, which is a pretty common scenario for a lot of people that we see. 3 years later, in 2014, she's 27 years old, but now she's 405 pounds and her BMI is 67. Still amazingly impressively, she's otherwise healthy. But in 2016, she's 29 years old. Her weight now increased to 425 pounds. Her BMI is 69. She definitely had significant depressive symptoms and was prescribed an SSRI for that. She developed type 2 diabetes mellitus and was on Lantus, insulin, and metformin. She also had developed or acquired obstructive sleep apnea and was using her CPAP. But at this time, she had no insurance coverage for bariatric surgery. In 2017, she had gotten married She did have a high-risk pregnancy. She developed preeclampsia. She ended up having to leave the workforce during her pregnancy. At 26 weeks gestational age, she did undergo a premature emergency C-section. Her child was born with significant heart defects. She traveled frequently from the Fox Valley to Children's Hospital in Wisconsin. The young boy had a trachea for the first 2 years of his life, also has cerebral palsy and a number of other health complications. In 2019, she continued to be married, but she was unemployed. She continued to make pretty frequent and regular trips from the Fox Valley to Children's Hospital in Wisconsin. She did have a second pregnancy and gave birth to a healthy daughter, but she was also experiencing significant domestic violence at this time. She was 32 years old, 400 pounds, and her BMI was 65. She had type 2 diabetes, hyperglycemia, chronic hypertension, anemia, GERD or acid reflux, obstructive sleep apnea, and she also developed bilateral knee and chronic pain and sciatica from lumbosacral spine and disc problems. So now, fast forward to December of 2020, almost 2 years ago, she was 33 years old, weighed 425 pounds, and her BMI was 69. She did manage to get a divorce and was now safe in her home with her son and daughter. Thankfully, her son is no longer trached at this point. She did have a desire to return to the workforce, but through the process, probably preconditioned to her domestic violence, but identified through her domestic violence, she also had post-traumatic stress disorder. Through the COVID pandemic, thankfully, she had better care through the state's Medicaid programming. And so she is scheduled and anticipating to have bariatric surgery in August of 2022. She's recently returned to work to the workforce in a temporary position with manufacturing, which is hopefully going to be a temp to perm employment situation. And she's looking forward to definitely continued health and improved health and longevity with her young children and employment, returning to the workforce, full-time permanent employment. And then lastly, I think we out of time? We're good?
We have about one or two more minutes left.
Okay, I'll do this one. So this is just a kind of a feel-good story. A 27-year-old male, not feel good for the majority of his life. He was severely physically abused by his father, and then he was sexually abused by both his mother and stepfather, was a victim of sex trafficking, was in multiple foster placements, and ultimately, after he aged out of the system, was homeless. Clearly had significant PTSD. In his mind, he didn't realize that there was anything wrong because he thought everybody had these experiences of nightmares, social avoidance, isolation, and this type of thing. And so this was his access point to treatment when he pursued bariatric service. This young man has absolutely no employment history. Obviously, he's morbidly obese. He's a bariatric surgery candidate. Through being a bariatric surgery candidate, that's when he was able to be identified as having PTSD. Thankfully, he was a positive responder to treatment. As an adult, he was figuratively adopted by a retired and very compassionate stranger on just a circumstantial, coincidental meeting. Last summer, he went on his first camping trip through this woman and just enjoyed himself despite his extreme morbid obesity. And he actually recently did undergo bariatric surgery. It's early in the process, but prior to surgery, I like to ask patients how they intend to take advantage of the benefits they receive from bariatric surgery. And his responses were rather touching and grounding. He talked about wanting to be able to go on hikes and camping, more hikes for the first time in his life. And he also said he looked forward to finding his first job and finding purpose in life. So thank you very much for your time and your patience. And Jen, it's all yours.
Thank you so much, Dr. Briggs. Excellent presentation. On to the Q&A session now, and I just want to ask each one of the doctors to mute themselves if they're not answering a question, because otherwise we've had some echo. So you can keep yourselves muted, and I'll ask you to unmute. I want to start with a comment that we received. Dr. Weber, a comment came in that said, "I wanted you to know Dr. Weber helped me lose 63 pounds and my BMI down 10. He's a great guy." So that was a nice comment from one of the audience members. So the first question is, and I'm going to present this question to Dr. Weber. Often providers gloss over weight as it's an uncomfortable topic and they don't think of it as a disease. Do you think that mentality is changing in the physician community, and particularly with primary care physicians who are on the front line?
Yeah, it definitely is changing, not nearly as fast as I think people on this call would like it to change, but certainly it's getting better. A lot of it has to do with just more knowledge we have about the pathophysiology and how it is a disease. It's easier to talk about it as a disease than as, you know, hey, you're not trying hard enough situation. But there are still plenty of patients I see who say, you know, my last doctor just, you know, not intentionally, probably meant well, but said something that was maybe offensive or didn't word something the right way. So, you know, at least in our center, I'd imagine some of the other centers too, we really emphasize training for our staff in the bariatric center, because not every person or provider wants to work with obesity, right? Just like, I don't want to deliver babies, nothing against babies, but, you know, that's not my area of interest. And so you want people who are really want to do the work and do really well with the communication. And we have training for that also. But yes, going in the right direction, not quickly enough, still working on it.
This next question is for Dr. Smith. Dr. Smith, do you take social determinants of health into consideration when treating patients?
Yes, we have to do that, and we look at everything. It's kind of a really holistic approach because, as they say, that helping somebody get on a meal plan, if it's not something that they're going to be able to do, then they're obviously not going to be able to sustain the weight loss. So we're looking at everything, and we can get quite creative in ways to help people that have social determinants. Not as many opportunities as we like. It's getting a little bit of more of a struggle right now as the more and more people seem to have the needs, but we definitely do include that.
Thank you. And then this last question is for Dr. Briggs. Dr. Briggs, can you tell me how you help patients who can't access healthy food to gain access to healthier ways to eat?
You know, it's a challenge, and that varies case by case, individual by individual, and what you know, just to echo some of the other issues that Dr. Weber and Dr. Smith had talked about in response to the questions. It is interesting as I review EMRs when I come across patients with a relatively healthy BMI at their primary care visit. It's always easy to identify that their weight is documented every visit. But when BMI start to get in the morbid and morbidly obese range, it's rarely documented every visit. And I think part of that is because of the discomfort of the issue between provider and patient. And any of us in the room that have had a BMI approaching or over 25 or more are familiar with visits to our primary care doctor and hearing the words, "You better start watching your weight. You just need to exercise more and eat better." And there are many times where I've wanted to say, geez, that's genius. I would have never thought of that myself. But it's a very frustrating experience for a person. So what we have to, it works best when we're able to work in multidisciplinary fashion with the nutritionist team, as well as the exercise physiologist, primary care, and some of the other healthcare providers on the treatment team. But if we're able to identify issues that work for the specific individual and expand on that, and tailor make a treatment plan that's germane to that specific individual, rather than trying to use a cookie cutter approach, one size fits all, and run everybody through the same diet because it's our favorite diet. You know, like Dr. Weber says, there's thousands of diets out there. And thousands of exercise programs, and the exercise equipment industry is multi-million-dollar industry. But I know I've got a treadmill that works a good clothes rack, you know, at my house. If it doesn't work for the individual, it's not going to work for anybody. And so we need to find out what works for that particular individual, what they see as doable and something that they're able to engage in and embrace successfully.
Thank you. Thank you all for your presentations today. We appreciate it so much. And I'm going to turn it back over to Melina at this point. Thank you all.
Thanks, Jen.
Yes, thank you so much, Jen. Dr. Briggs, if I knew then what I know now, right? We should start with our minds when we're young, mature minds, and then become children later on. I don't know what to say. This was the passion. You all could see the passion of our physicians. They're absolutely amazing. So thank you, Jen, very much. I am now pleased to introduce our employer speakers for today. And Abby, Teresa, and Lauren, if you could come online, if you can bring your cameras on. Yes, that's fantastic. Good morning, ladies. Thank you. We are very excited to now get the employer's perspective on what you're seeing in your employee populations. I would like to first introduce each one of you, then ask each one of you to give us about 3 minutes, 3-4 minutes of your company and your efforts in the area of health and wellness, and of course with an emphasis on weight management and obesity. And then we have many questions that are coming in from the audience. So first, I'd like to introduce Abby Ammerman. I have my notes. Abby Ammerman from HEB in San Antonio, Texas. She leads the health strategy and communications team for HEB. I think many of us know HEB is a grocery retailer in Texas and Mexico with 120,000 partners. I love this, Abby. The employees are called partners at HEB. That's fantastic. Prior to HEB, Abby worked for Cooper Wellness Strategies and also for Cigna Healthcare as a consultant. She has been in the employee health and welfare industry for the past 14 years, designing, implementing, and evaluating programs for large employer groups. She holds a master's degree in public health with an emphasis on health promotion in the workplace from the University of North Texas Health Science Center, and a bachelor's degree in organizational communications from Ohio University. So she is a fellow Ohioan, which is where I grew up as well. Outside of work, Abby is a military wife, a mom, and a competitive triathlete. Next, I would like to welcome Teresa Palvemacher. Teresa is an advanced practice nurse practitioner and also a family nurse practitioner. She serves as the president and medical director for Weber Health Logistics and its healthcare affiliate. Teresa serves as a liaison between corporate and small business partners and within the healthcare realm. In her work, she works with small and large employers to ensure that there is a return on their healthcare investment through cost containment programs. She works in tandem with corporate players in her community and their teams of health and wellness experts to realize their organization's desired goals and outcomes. In her role as a president of the Weber Health Logistics and affiliated healthcare entity, Teresa's overarching goals are to guide the integration of wellness and lifestyle initiatives with clinical innovations to bring a new healthcare model to the forefront of reform. Teresa, as I said, is a family nurse practitioner, so for her own organization, she serves as a primary care provider as needed for her employees and their family members. Teresa is a long-term resident of Southwest Wisconsin, Cooley region, along with her husband, Gary, 5 children, growing number of grandchildren. She began her health education at the University of Wisconsin-La Crosse and completed adult and family nurse practitioner training at Viterbo University. And I had the pleasure to meet Teresa and her team several months ago. And we plan to work quite collaboratively in the future, as she is part of the community, the Alliance community. Last but not least, Lauren Schreib. Lauren was raised in Marshfield, Wisconsin. She received her degree in Human Resources, Management and Organizational Learning and Development from Rasmussen College, and has worked in the insurance industry since 2012. Lauren began her career with Aspirus in 2015, first working in human resources, and in 2019 moved to the Aspirus Health Plan. Lauren has served initially as an account manager with Aspirus Health Plan, and later she moved to the Director of Operations. So a very, very warm welcome to all of you. I would like to turn it to Abby, if I may. Abby, if you can give us a few minutes with a short description of your company and some of the amazing work that I know and I have seen you're doing.
Sure, absolutely. Thank you so much, Melina. Good morning, everybody. As Melina mentioned, HEB is a grocery retailer, but we're actually a little bit more than just a grocery retailer. We manufacture our own products, we store our own products, we transport our own products, and other products, of course, between stores across the great state of Texas. We are also starting to be a little bit of a healthcare company with the onset of our own direct primary care clinics that we're offering services for our partners and also community members. We are a privately held company, partner-owned organization rooted in a very people-first culture that took shape over 117 years ago. The mission of our benefits team is to support our partners in reaching their fullest potential by providing affordable, accessible, and frictionless benefits for our partners and, of course, their family members that utilize our benefits as well. We're really looking to put forth programs and services that support them in all of their health and well-being needs, no matter where they are on the spectrum. Each year, we ask our partners and their spouses to complete a health screening as part of our outcomes-based wellness program. It's called Healthy at HEB. Our program requires our partners to meet Healthy at HEB biometric standards or show an improvement over their last screening in order to earn a premium-based incentive. Our most prevalent risk factor is overweight and obesity. Really, the only way that we can see this risk factor come up is through our biometric screening results. So we kind of take that very seriously. It doesn't necessarily show up in our claims, either on the medical side or the pharmacy side. So we use this information to help us to provide and stand up the right resources and the right benefits for our partners. We really look to provide value-based benefits. So what's going to be meaningful to them, what's something that they can afford, what's something we can do for them for free to influence and help them manage their own health. A few things that we offer. We do cover 3 registered dietitian consultations annually. After that, it's a low copay if they need to go for additional visits throughout the remainder of the year. Our pharmacy plan, the majority of our stores have a pharmacy in them, so we have a closed network pharmacy plan, and we also have a pharmacy call center that is staffed with pharmacists and pharmacy technicians, and they can help us manage medications, do MTM, work on custom prior authorization processes for anti-obesity medications specifically, as well as diabetes. So we provide reduced copays once partners do engage or members engage in any of those programs. Our pharmacies also perform all of our biometric screenings. So we have a wealth of data for over the past, 12 years that we've been screening our partners. We also work with a third-party point solution called Onduo for our diabetes management. As I mentioned, we have direct primary care clinics that are owned and operated by HEB. This includes things like health coaching. We have a clinical pharmacist on staff. We do case management and also have a specialist referral network. For EAP, we worked with our EAP company a few years ago when we started our outcomes-based program to procure a network of clinicians who could do motivational interviewing, who could help with goal setting, things like that for those partners and members who needed help just kind of getting started down the right path. And then we also do cover bariatric surgery that have to be performed at a center of excellence. We have seen success in moving the needle on the prevalence of obesity within our cohort population, so the same folks that we screened every year. In year one of our outcomes-based wellness program, we saw a significant reduction in the prevalence of obesity amongst that population, as well as elevated blood pressure, blood glucose, and cholesterol, which again just goes to show that obesity, reducing weight, does impact the remainder of the chronic conditions. We also saw the average number of risk factors for our total population decrease as well, so fewer people with those 3, 4, and 5 risk factors. And so we picked up screenings again in 2021 after a hiatus in 2020 due to COVID. And also in 2022, we just finished our screening campaign and we were tracking towards our improvement goals again. So we're looking forward to seeing what our outcomes of screenings were this year. Thanks.
That's fantastic, Abby. Thank you very much. Teresa, may I invite you to tell us about some of the great things you're doing in the La Crosse region?
Sure. First of all, I have to apologize. I don't know if you heard the noise in the background, and even your best laid plans don't always work. We're undergoing some critical roof repair, and it's very noisy. And so if you hear drills, we tried to plan around that, but it's not going to work. So if it is distracting, I apologize. So like Melina said, I am a family nurse practitioner, and I have been with a Weber Group business for the last 17 years. And we started, unlike Abby, we are a very small organization that it's kind of a grassroots effort. We started at a corporate level here in La Crosse with a Don Weber business called Logistics Health, and we built a wellness program specifically. Sorry, it's okay, you can hear it. Oh, good. So I'm also going to be distracted. We built a corporate wellness program specifically for them. And what happened from that point forward is we became very obvious in our community that we were doing something that was different. And that was 17 years ago. And from that we grew. We do a lot of the same kinds of things that Abby and her larger company do, but at a much smaller level, like biometrics. But one of the things that we've done that is a bit unique is, and it takes a lot of executive level support to do things like wellness time, but we implemented a wellness time program where the employees are paid 3 hours per week to get some kind of physical activity or to do something wellness. So that includes, the programming includes family and dependents, spouses and dependents. So if an employee needs to take a child to a well child visit, that's also critically important, and that's one of the things that is covered by wellness time. So, and we've done things like walking programs, and that's included in the paid wellness time. So bariatric surgery is covered. So that's one thing I learned about in the last couple of days. So I appreciate that question. Let's see, I don't have quite a whole lot more that I can offer than we are a grassroots effort. And one of the things that we learned as a result of COVID is that we have a whole population that we have not ignored, but didn't address in the right way. So it was really very interesting to listen to the speakers and to hear that we're on the right path. We are taking a really close look at things like socioeconomic status and what people actually, what we make. And the business that I work for really is 17 different small businesses. So what we're doing is moving away from that corporate focus, which we've done really well for 17 years, but we're taking a look at small business. And what we want to do is learn more about that population and what motivates them, because what we've done for 17 years, and you can't offer the same wellness programming to a corporate employee, to a disher or a housekeeper. So we're really getting down in the weeds with them. And I've learned so much in the last couple of days. I could spend a whole hour telling you what we've learned, but we're really going to adjust what we've done in terms of our programming. So check back in 6 months and I'll let you know, because we're revamping everything that we're doing based on what we're studying in our population. And I think that's kind of critical.
That's fantastic, and you betcha I'm going to be there in 6 months. You know I will be.
I'm so excited to the things that we've learned just in the last week. I wish I could share because it really is very exciting. Oh, one more last thing. We own a clinic, and I didn't even.
Yeah, that's right.
Didn't even touch on that. We have a primary care clinic, and all of our employees and those people the people that use our services, it can be a fully subsidized model. So our employees in all of the Weber businesses can use full primary care at no cost. So that gives us an amazing avenue to reach our employees.
And I think, Teresa, because Teresa and I have worked together, and I know more than I know from Lauren and Abby about their business, but you're building a brand new facility that you want to open up to the La Crosse region, right? Do you want to just give us 30 seconds?
Yes, it's scheduled to open in October, and we're going to look at several different payment options. So we're looking at offering very affordable, potentially cash paying customers, and a direct primary care, a direct payment model. So and also insurance. So it's going to be very exciting. It's brand new. We will offer full primary care. We have a psychiatrist that has come on board because, and you've heard it through all of the speeches today. You can't address the chronic disease without looking at behavioral health. So that's going to be a huge part of what we do. We have behavioral health now as integrated into primary care. And as a healthcare provider, that's been amazing for me to be able to actually knock on the wall and say, can you come in and talk to my patient? But we're going to expand that in our primary care clinic, and that's scheduled to open in October.
Thank you very much, Teresa. Lauren, may I ask you to join us now and talk to us about Aspirus and Aspirus Health Plan?
Absolutely. Good morning, everyone. My name is Lauren Schrage. I'm the Director of Operations for Aspirus Health Plan. We are a health plan that's located primarily in central Wisconsin, stretching up into the north. We also are a provider-owned health plan, so we insure Aspirus as the larger health system, about 15,000 members on that group, in addition to on-exchange business, small and large group fully insured and self-funded, and Medicare Advantage. So as Melina had alluded to earlier, my role originally was with Aspirus started on the HR side and then moved into the health plan side in the last few years. I was able to be the account manager for about 1.5 years on the Aspirus employee group, which is really when I would say our larger focus on obesity had started. We've offered bariatric surgery coverage for a number of years. We offer nutritional counseling covered at 100%. But in the last few years, we've really started to focus on where are we seeing some trends and utilization and cost, in addition to our wellness program and our biometric and HRA data. So we've utilized the data primarily from the Aspirus employee group, with it being our largest group, to identify trends like musculoskeletal, which we've heard a lot about today. We saw a decrease in our ideal BMI range for our wellness participants, which led us to dig into what else can we offer in that space. And it's really led us down the path of, in the last 2 years, offering a digital wellness program or a digital weight loss program. They're called Wonder Health. That's new as of 2021 for our employees. We offer exercise rewards that allows members to be rewarded via a gym visit 10 times a month for a half hour, online digital gym classes. We have just added this year weight loss drugs to our formulary, which is very new and I think something we might hear a little bit more about in this last half hour. We also have a Csa program where we partner with a local farmer, and we have fresh food that can be picked up for members that are part of our disease management program. We've had wonderful feedback and results through that program. And right now we continue to look at ways that we can expand, focusing hopefully in the next year on an additional mental health covering. So happy to be here. Thank you, Melina.
Yeah, no, that is fantastic. And I just want to mention, I am pretty certain, you can tell me if I'm wrong, all 3 employers that are presenting here today, you're all self-funded, right? So you can manage your own benefits and you know, add or delete things, right?
Mm-hmm.
Yeah. So my first question I'm going to ask all of you, because I believe that you each have very unique characteristics with your workforce, whether the workforce is spread across the entire state of Texas and northern Mexico, or spread within Wisconsin. How do you engage your employees on the topic of obesity without making them feel uncomfortable? We heard Dr. Briggs, some of the very uncomfortable issues that happen in the workplace. How do you do that? Abby, can I start with you? Do you mind?
Certainly. So for us, we really try and take a, I guess, agnostic approach. So we will target based off of certain data that we have, but we won't call it out and say, hey, employee, because your BMI was over, X, we're sending you this message. We really try to stay away from highlighting one specific program to individuals instead of providing them with a few options that might impact or help them to improve their health. And then we usually just try and keep the message very positive. Again, always circling back to making just tiny improvements in their health. And it really kind of obviously for the incentive reason, so helping them to save money on their health care and also getting healthier. So that's kind of how we approach it.
Thank you. And Lauren?
I would say we're very similar to Abby from an employer perspective. We have additional programs through our wellness program, and we have a comprehensive care coordination program that focuses on diabetes, hypertension, CHF, and obesity. So sometimes those more targeted conversations can take place with a health coach or a care coordinator or at the physician level. But from an employer perspective, we're trying to meet members where they're at and offer tools and solutions and keep it fairly generalized.
Thank you. And Teresa, your example may be a little different because you're also a provider, so you get to have these one-on-one interactions with patients as well.
It's a really good question. Because as a healthcare provider, I was taught to be very straight to the point and to understand that it's a medical diagnosis. And when I did my residency, I worked with a military doctor who would just tell me, you got to say, it is what it is. And in my experience, that tends to shut people down. So we do address it from many different avenues, give lots of options from fitness coaches. We offer some subsidized fitness training. We have lots of integrated services, including behavioral health, as I mentioned. But we've been very fortunate as we built our primary care program and the integrated piece of the behavioral health that addresses obesity to work with our registered dietitian that was trained at Rogers. So and in talking about eating disorders and disordered eating. So I'm going to sound like a broken record because I'm going to sound just like Dr. Weber, but when we talk about obesity, we address it. It's not that we ignore it, but we talk about a healthier weight, and we talk about that 5 to 10% weight reduction to that as a way to ameliorate a disease. And the best example I can think of in my own practice is when we talk about the osteoarthritis, and it's a patient can understand how carrying too much weight and just how losing 5 to 10% of their body weight can make a huge difference. You tell them things like, you have to understand your knees. They bear 100%, 150% of your body weight when you're walking. And if you just drop 10 pounds, you're losing 40 pounds of force. So things like that, we've found ways through training, like Dr. Weber said, we have trained our providers. And because we own the clinic, we have the opportunity to do things like that. And once you have those kind of conversations, it's easier to lead into other topics like the inflammation associated with weight gain and all the things we've talked about today, cardiovascular disease, diabetes, renal. The approach, like as with osteoarthritis, is it's a lot less overwhelming, and the support and encouragement that we give them during that 5 to 10% weight loss is critical, and that's where our behavioral health specialists come in, behavioral and coaches. They use techniques like motivational interviewing, solution-focused therapy, mindfulness to address those behaviors. Lastly, as I mentioned, we're learning more and more about our new population more every day. We ask culture questions, and we consider the social indicators of health, socioeconomic status in all of our communications when we talk about obesity.
So that's fantastic. Let's talk about communications. I will again ask the question of all three of you, but I will start with Lauren, because Lauren, I heard you say we want to meet our employees and their families I assume their families, your plan participants, where they want to be met, right? So what are the different communication channels that you're using to talk about wellness and of course this remarkable disease as well, obesity?
Sure. So our wellness program is something we've developed internally through Aspirus, and we identify wellness coaches in each of our departments, or a wellness champ is their title. So they're an employee that is invested in the wellness program and is kind of taking all of that information that we're sharing back to their department and educating on any quarterly events that we might have, or maybe we're highlighting a new program this month, or we're looking at upcoming deadlines for our HRA and our biometrics so that everyone can earn their insurance incentive or their premium incentive. So we really rely on those folks to take some of that targeted program messaging into the department and field questions. We also utilize an online tool. It's basically an email tool. It's called Aspirus News Now. It's a weekly update that gives every department across our system an opportunity to give this whole system an update on what's happening. So HR uses that as a primary communication vehicle. That's a way to just get mass amounts of information out at once. We use our new hire orientation to communicate on program options, our annual benefits enrollment period we use. We've done some postcard engagement through both the health plan and Aspirus as an employer. So that's kind of our general focus. And then again, we have our care coordination program, which is a more targeted program available to members that have certain disease states or complex care needs, where they can set goals with a nurse and really be informed about programs that might be a better fit for them.
So, and I want to mention that Lauren and Aspirus, of course, are members of WCHQ. So we've been working very closely for the past several months. There is a handout that is available for the audience to download now, and then later on it's going to be on our websites as well. And we fashioned that handout in part on the Aspirus Health Plan program and some of the work that Lauren has been doing. So thank you very much for that. Abby, may I ask you that same question? And I know some of the incredible things you're doing because I've listened to your presentation before. Your challenge, of course, is that you're trying to reach your partners across a large geography and multiple stores. So your experience may be slightly different.
Yes, yeah. We actually also have wellness champions who we rely heavily on. Each of our stores and facilities has an individual partner that we call an admin, and they're sort of like the mama hen of the work location. A lot of times they pick up the wellness champion responsibilities, but then there's also times where we have just other partners who are interested in it. And we bring that group together at least once a year for a big summit. We usually go in person. We're going to pick back up in-person summits this year. It's just prior to annual enrollment. And again, we use them as a vehicle for getting the word out there about different programs and services available to our partners. We also meet with them on a monthly basis. We hold a webinar for them to come and call in so that we can really keep them up to date as frequent as possible. We also use the standard communication channels like email and text messaging. We have posts on our PartnerNet, which is our intranet page, with stories and things where people can leave comments and kind of hear back from folks from our communications team. And then we do a lot of videos. So sometimes we use characters, sometimes we use senior leaders, sometimes, I've done videos before. We just try and keep people engaged, and videos actually seem to be one of the better ways to really communicate things and reach our partners.
Wow, we all need to get into vlogging, right? Yes. Teresa, could I ask the same question of you, different communication channels?
Absolutely. Well, as you all now know, our employees all receive full primary care at no cost as part of their healthcare benefit. So our providers are really the first line of communication, and they have received extra education in medical weight loss and all the integrated services that we provide. And they use approaches that include motivational interviewing and behavioral health techniques. But beyond that, we use every means possible, from one-on-one group events like biometric screenings to large events like a health expo. And we've had, really good participation with these. Like our Health Expo, one year we had over 700 people attend. So that was really big in this small community. Our RD has an active blog. We are in a community where there's lots and lots of health education. We have a nursing school here, and we have the University of Wisconsin Western Campus. We have a very active student population. So we actively engage these students, and we rarely function without an intern or two here that help us with things like bulletin boards. And we have certified health education specialists that write wellness tips. They do in-person or virtual presentations. And one of the things that we're doing now, as we're addressing this new population, we're looking at theories like social media theory and media effects theories to learn the best way to contribute communications to this population. I don't think I mentioned, but our new population is the service and hospitality industry. And if you think about it, they are a group of people that really has been ignored with healthcare benefits. So we're really trying to wrap our arms around them and understand what they need. So that's why I said, stay tuned. We'll learn a whole different way to communicate that with that group, because it's a whole different story there. You can't communicate with a housekeeper and using the same modalities that we've used in the past for our administrators or our customer service employee. So stay tuned. We'll let you know what we've learned, but we'll use whatever means we can. And we are actively building an app to use, because in our communication and in our research, we've learned that that's what they want. So we'll see how that goes.
Oh, that is fantastic. Yes, thank you. So 2 trains of thought here, and I have some questions in front of me that kind of fit in a couple of different buckets. Let me just start first with data and then statistics on success. Let me just start with data. So one of the questions we have is, what is the best data that an employer can reference to identify obesity? And I know I've heard a little bit from you ladies on biometrics data. Would you like to elaborate? Abby, may I start with you? Do you mind?
Sure, certainly. Yes, so I think I mentioned a little bit earlier that we own all of our data and through our pharmacy team. And so we use our biometric data, one, namely because I think we can all agree it's a great population health metric, BMI being a great population health metric to kind of measure across a very large population. And that really is one of the only ways that we can assess obesity, because in Texas, our clinicians do not code for obesity and claims, so it hardly ever shows up on the medical plan side. We are also, of course, covering anti-obesity medications. Those, of course, we can track, and we can see how many folks are taking those. And we do have some like BMI and weight data through that program that we work with. So we do lean heavily on our biometrics, knowing though that those results and what we see there is going to vary greatly from what we see on the medical plan side. So we do try to come up with a way to measure cost savings and overlap, and also to identify folks who don't even show up on the medical plan side. We've got a fairly significant portion of our population that doesn't even access care at all, even though they pay for insurance. So that's what we use. We use all of our claims data, we use all of our biometrics data, and then we run like individual little studies every now and then. Like we're actually doing one right now on our anti-obesity medication population, and just kind of trying to understand what happened to them over the course of the past couple of years. How long have people stayed on the medication? Did their health improve year over year? So we do little things like that. Like we've also done a study looking at our registered dietitian utilization and the partners who engage with that team. And we found that they had more significant health improvement, and they also showed cost savings. So we're very active in that part of the business, and we have a data warehouse where we keep everything and then can correlate things. So we're very fortunate to have a lot of data at our fingertips, and we try and use it in unique ways.
And so that's fantastic. Let me just stay with you just for a second, Abby.
Sure.
So you own the data, you have a data warehouse, so I assume you're doing a lot of the analysis internally as well, or are you using your third-party administrator or your broker consultant for some of that help?
We do everything in-house at HEB. We don't really work with a broker or a consultant. Yeah, we have an analytics team. So I will say we have help, a healthcare analytics team that does really great work. So we rely heavily on them.
That is fantastic. That is phenomenal. So thank you for that. Lauren, same question to you. What type of, and I know, Lauren, you've been going through a journey here, and I know that soon you'll be coming out with some statistics that, of course, at WCHQ, we would love to see. Can you talk to us a little bit about the data and then maybe statistics that you may have on success of your engagement strategies?
A journey is a great way to put it, Melina. Yeah, so we right now, our first year or two of introducing these new programs was to grow engagement and to get participation so that we could get a large enough cohort of individuals to track pre and post claims data and pre and post biometrics data. I would say right now our biggest focus is biometrics data. That's what we can get a little bit more targeted with when you look at your medical data, aligning with what Abby said. Not everyone codes for obesity, so we can pull our claims costs and we can see that we might have a trend like most health plans in musculoskeletal, but we can't always tie it back to obesity necessarily. So right now, a big pilot that we're focusing on is in 2022, opening up our formularies to cover weight loss drugs and tracking those pre and post biometrics at 6 months of utilization, which will be in the fall here for us, and then at 1 year. So I would say that that'll be something that we'll be excited to share and that we're really excited to see the results of.
And I think we would all agree, right, that this is, and the reason why I called it a journey, and I know you all are looking at it as a journey as well, this needs to be part of our strategic planning in healthcare, right? This isn't something that, and our employers, our audience needs to understand, and I believe they do, you can't just change from the 1 minute to the next. So there needs to be a strategic plan in place, and we slowly get to the results. That's what I'm hearing from both Lauren and Abby. And of course, Teresa, same question to you. What data, again, different, you're a different entity. So what data are you using, and then what are some of your success statistics?
Well, like my other presenters here, biometrics remains the mainstay of what we do. We do those annually, but we do all of our own analysis. We have certified health education specialists that's their job, is to analyze the data and develop new programming based on that data. But we've kept other statistics over time, and journey is perfect because we've learned over the course of 17 years that some of the data that we've collected doesn't really have any meaning. Well, it has meaning, but it changes based on the population and what's going on in the world, like COVID. So, but some of the other data that we've kept we found kind of unique ways to evaluate presenteeism. We look at absenteeism. We monitor the number of sick days that employees call in for. So we ask questions about job satisfaction, number of hours of sleep, how much exercise they're getting, and we use all of that data to determine what kind of programming is going to work best. So for our new population, it's going to be different. We haven't had access to claims data, and again, a lot of this might be helpful to small organizations that are trying to grow wellness programs, things that you can look at as a small organization. You know, we're talking our population being smaller restaurants, and what kind of data can they look at? So we'll figure that out. Mostly, I think the biometric data is going to be critically important to absenteeism, job satisfaction. You know, what's going to keep those employees with you, and providing this kind of healthcare benefit is probably a great retention recruitment tool in an industry that's suffering. So again, biometric data, it's critical. Year over year, we look at that and develop our programming from that, but there are lots of other things that we're going to learn about. And we just talked yesterday about what truly are our outcomes that we're trying to measure, and we want to look at things in a more positive light. So we want to look at the spectrum of change and figure out ways to monitor whether or not we've made a difference. For example, tobacco cessation. A lot of the typical programs want people to set a quit date, but really what we've learned about vaping is that a lot of people don't even understand that they're doing damage. So if we can measure whether or not we've moved them along that spectrum of education, and we're going to figure out how to do that. So there's a lot of data yet to be found, and I don't have any of that new stuff yet.
Yeah, no, that's fantastic. Another great question that we have here, and this is, I think, is going to be more applicable to Lauren and Abby, but how do you work with, as an employer, how do you work with providers that are servicing your employees to ensure they are reiterating the importance of a healthy lifestyle and the importance of controlling weight? Again, you're all sort of in the space of providing health, not sort of, but you are. You're more than just your organization. You've taken this very seriously. But I'm wondering if you've had these interactions with physicians, outside of your system or within your system, of taking this disease epidemic of obesity very seriously. Abby, I will start with you again.
Okay. Yeah, so as I mentioned, we own, I guess we are up to like 7 or so clinics where we have family practice mostly, or internists practicing medicine alongside nurse practitioners and medical assistants. And so those clinics really are designed with our true, I guess, beacon for what healthcare should be. And so we hire very specifically clinicians who seem to practice or have experience practicing under a true direct primary care model. And they kind of refer then within the model to the health coaches and the clinical pharmacists and PT, chiro, et cetera. And then from there, we started, I guess it's been, I don't know, 4 or 5 years that we started our, we call it our HB Wellness Primary Care Physician Alliance, where we were going out working, we actually came up with a cost and quality metric where we were identifying physicians in the specialty areas that were most prevalent amongst our population, and then going and taking meetings with them and talking to them about our philosophy and our strategy, and just having open and honest conversations with them about, hey, we'd really like to refer our members to you. And that seemed to go well. We're not exchanging any money, we're not giving them anything in return, but we feel good knowing that they're good quality physicians and that our members are going to receive great care there. So that's something that we've done beyond, I guess, the 4 walls of our clinics, and that's proven to be pretty effective.
And at some point you mentioned centers of excellence. Can you help us with what you mean by that?
Yeah, so that was for our bariatric program, and we actually use our health plan to define or I guess identify. They're called Blue. We use Blue Cross Blue Shield of Texas, and they're called Blue Distinction Centers for bariatric surgery. So that's what we use today, and it is just for bariatric surgery. We don't necessarily have a larger centers of excellence program where we refer members, but we do rely heavily on Blue Cross for anything like. We do a lot of transplants that we'll send out. Obviously, those are kind of few and far between, fortunately, but we do send transplants usually to a centers of excellence as well.
Thank you. Yes, thank you for the distinction. Absolutely. Lauren, you as well, you work within a large system. You have a lot of employees. Many of them are providers, not just physicians, but providers. What is the communication between the health plan, the work that you're doing on health and wellness for your employees and their families, and your physicians, in terms of reiterating that this is a disease, it is an epidemic, healthy lifestyle will save lives?
Because we're provider owned, I think that sometimes helps in our communication vehicles. We have a lot of our physician leaders that serve on various committees throughout the system that focus on things like quality and wellness and how we're designing our benefits plan for Aspirus, for our Aspirus employee group. So we have a lot of physician input, and I think that really helps as communication step number 1 to spread that information across the different departments. I think when you look externally at the different, as a health plan, provider systems that we're partnered with and that are part of our network, there's always room to improve and to build additional information into things like your quarterly provider newsletters. Right now, our big focus is on anything that our quality programs are supporting, and we're still building obesity into that. We have a big focus on diabetes and hypertension, so I think adding obesity as a third focus is going to fit very, very nicely in the future. But right now, we issue a quarterly provider newsletter that'll outline any programs, primarily programs that are kind of fielded through, again, that comprehensive care management program that providers can refer members into.
Thank you, Lauren. Teresa, I think you've mentioned a few things in relating to this question, but something more to add on that?
I can just reiterate that we're incredibly lucky to own the clinic and to be building a new clinic, because we've been very selective as to who we've chosen for our providers. We fully support their efforts. They have excellent provider scores in chronic disease. That's one of the things that we do measure. But I don't know, that the biggest thing with our providers is instilling confidence in them to actually treat obesity as a disease. So that's an ongoing effort there, and myself included. It was a hard jump for me to use medications that I've used every day in treating, disease processes to use them to treat obesity. So that's been probably one of our biggest challenges. But our providers are wonderful, but it has taken extra training to get them to have the confidence to understand and believe what they're doing is going to make a difference.
Yes, thank you very much, ladies. One last question before I ask for maybe your closing comments, if you would like to add anything, something additional. So, we've got a very specific question that says, give us examples of wellness initiatives. I am going to change the question a little bit, and I'm going to ask, and I'm making an assumption that I know the answer to that, so correct me if I'm wrong, but I don't believe that I've heard you say there is one silver bullet, one thing that works, not only for health and wellness, but specifically for obesity. It's really a conglomerate. It's a lot of puzzle pieces that we need to put together. Maybe talk a little bit about that. Teresa, would you agree, disagree? Have you found just one very, very specific thing that works the best, or is it everything and all that you do every single day?
You're absolutely right that it's a puzzle. And it takes a very integrated, coordinated effort. And I think recognizing that is critically important. But for us, the one thing that we found that has made a huge difference is that behavioral health component. Without it, I don't think we would succeed. We can tell people to get 30 minutes of exercise a day and give them nutrition education, but if you're not going to address the underlying behavior, you're not going to get anywhere. So that's the biggest impetus for us, is that behavioral health. And we've gotten such positive feedback that I would say you really can't address it without having a firm foundation in behavioral health.
I love that. Thank you for pointing that out.
Thank goodness.
Yes, no, that is very important. That's why we had and Dr. Briggs. I mean, he spoke to my heart. So
it was amazing.
He truly is. Lauren, same question to you. Have you found, is it everything, or have you found something? And actually, just to put you on the spot, you offer behavioral health in your health and wellness as well, right?
We do. We have an EAP program available to our members or and employees as well. But no, there's not one thing that we can focus on completely. And that's why I really like to use the terms meeting members where they're at. We offer the gym program, for example, where there were probably some pushbacks that we received initially, where we're getting the feedback of, well, your healthy people are going to go to the gym. Well, that's great. We'd like our healthy or potentially rising risk members to go to the gym and to continue those healthy habits. And then what else can we offer? Or maybe they work with a colleague who doesn't have the confidence to go, and now they go together. So I think it's just offering a number of different programs and making things available to folks, and supporting that, on the employer side. I would say having a gym reimbursement is a huge recruitment tool and benefit as well, in addition to a digital weight loss program. So I think that having these tools that are low with not any cost to members available, just help meet people maybe with a program that they never thought about doing before until it was offered as part of their benefits.
Yes, absolutely. Yes, thank you, Lauren. Abby, last word to you. Same question, or if any last parting words at this point?
Yeah, I mean, that question kind of just made me think about some of our messaging around our solutions. I mean, our former program, we used to require people to complete certain classes or do certain things and didn't really move the needle. I think when we just said, hey, we're going to try and provide some really great resources that we've vetted and we're putting forth for you to access if you want, take accountability for your health, take ownership of your health. That's kind of a phrase that we use a lot. That has been, I think, a great thing for our members and our partners. And I do think as well that there is something to be said about the behavioral side of this. When we moved to an outcomes-based program, when we said, you know, just make a 3% improvement in your health, there was something about that that really kind of worked with people. And so I'm super interested in the behavioral economic side of this thing. And, you know, I think it would be really interesting to kind of continue to look at that as employer-sponsored wellness programs continue to evolve.
And that is a great idea for potentially a topic later on, right? Yes. Ladies, your passion is amazing. You're making me so excited to be able to work with all of you. I would like to invite you back again in a few months. This is actually our second health and wellness employer panel, second time that we're doing this. It has been very successful. It's an area where we at the end of the day all need to learn from each other. So I would love for you to join us again, and maybe we'll make it around the behavioral aspect, because I also believe that is very important. So thank you so much for joining today.
Thank you.
Thank you for inviting me.
Thank you to all of our guest speakers. Right, great presentations, great speakers. To everyone who attended and participated in today's questions, very enlightening. You know, you can tell I'm very passionate about this. And again, if I knew then what I know now, if I knew at 30 that going to the gym every day is going to be important when I'm 57, maybe I wouldn't be dealing with obesity today. But never too late. Just a couple of last housekeeping tips here. To download today's handouts, click the handouts drop down on your screen. The presentations and the handouts from today's event will also be made available on our events page on our website. Also, as I said in the beginning of this, Jen Koberstein and WCHQ will also make these presentations available. Please, you will receive an email following today's event with a very short survey. Tell us how we're doing. Tell us what we can do better. We appreciate your feedback. We work tirelessly. The marketing team and the technical team work tirelessly to improve this event and bring you as much value as possible. There will also be directions on how to apply for CE credits. Save the date for our fall symposium and annual meeting on Tuesday, October 25th at Monona Terrace. We're also working on an event around how employers can use data to make better benefit plan design decisions. So keep an eye out for that as well. This is all from us today. Thank you, thank you. Thank you for the privilege of your time today. Have a great day.